Hello students, I'm the OGGuru Dr. Punit Bhojani here with a single point agenda to make OBGY your most scoring subject and most favorite subject. Welcome to the session. In today's session, I'm going to discuss the top 50 expected one-liners in OBGY for the upcoming FMGE examination. And do get in touch with me on phone and WhatsApp on this number for your personalized timetable guidance. Feel free to call me or WhatsApp me. I'm there to help you out for your exam preparation. Now, these one-liners are really important, and I will also be giving you the concept, because if the one-liner is twisted or if they apply it in a clinical case, you will also be able to answer. So this is not only mug up. Once you understand the concept, any MCQ in the world you can answer. Okay, and do not forget to download the OGGuru app on the Android and the iOS. For iOS, we will have to put the ORG code YYMSTV. So many students joining the app every day and thanking me that, sir, we are able to master and revise the entire OBGY just in few days time under your guidance. Okay, and this, my dear student, is your best chance. Still 3 months left for the FMG. Dates are not yet announced. It will be in the month of July. So do enroll in this masterclass where just under few days time, just you need to dedicate 30 to 40 hours time and you will be able to master OBGY. There's theory lecture, rapid revision MCQs, beautiful handwritten notes, more, and of course my timetable guidance. More about this after some time towards the end. Okay, so now let us begin our discussion. First one-liner: earliest to detect pregnancy. Now please understand this. What is this MCQ? That which test or which investigation? And the next one-liner: earliest to detect live pregnancy. Now is both of them same? Okay, only one word. No, both of them are different. The only one word different is live. Now please understand this. When this question comes, majority student mark urine pregnancy test as the answer. Wrong. Please understand this, that the urine pregnancy test जो हम करते हैं, 2 drops we put and we get that 2 line. Okay, and kabhi khushi kabhi gum. Why kabhi khushi kabhi gum? Because if the pregnancy is planned, you are happy. If it's unplanned, you are sad. Okay, so 2 lines come in that kit. Okay, Prega Sure, Prega, all the brand names and all the heroines are there for the brand ambassador. Okay, Anushka Sharma, Katrina Kaif, all these are promoting this urine pregnancy test kit. Okay, so please understand this, that the urine pregnancy test or the UPT, what we do is detecting urinary HCG. But even before the HCG is secreted in the urine, the blood, serum beta HCG is the answer. Why? Because my dear student, the serum beta HCG is positive even before the missed periods. Okay, so what you need to keep in mind is that the UPT or the urine pregnancy test is always positive after missed periods, after when the female misses her periods, after missed periods. But earliest, if I want to detect pregnancy, why serum beta HCG? Because please understand this, suppose it is a 28-day cycle and the ovulation happens on the 14th day and the embryo is traveling. When does the implantation take place? One more important MCQ, sir. Implantation takes place 6 days following fertilization. 6 days after fertilization, which is roughly day 20 to day 21 of the cycle. And the technology is so advanced, 21st day implantation, as early as 22nd day, as early as 22nd, 23rd day, the beta HCG in the blood. So that is your serum beta HCG will become positive. So you can see over here, somewhere over here, all this, the beta HCG will be positive. Patient has not even missed her periods. Is this understood to all of you? So please keep this point in mind, that, sir, the serum beta HCG is the earliest to detect pregnancy because it is positive. It is going to be positive even before missed periods. Is this understood to all of you? Even before the patient, even before the missed periods, the serum beta HCG is positive. Okay, but earliest to detect live pregnancy, anybody, when I want to detect live pregnancy, baby बोलता है जिंदा हूं मैं, how do I know? So that is when I see the fetal cardiac activity, and that is on transvaginal sonography. Anybody, how early? Sir, as early as 6 weeks. Newer machine, even you can write 5 weeks 5 days. Okay, 5 weeks 5 days. So very important. But even if you remember 6 weeks is okay. So by 5 weeks 5 days or 6 weeks on transvaginal sonography, I can say it is a live pregnancy, because for live pregnancy I need to see the baby heartbeat flickering, that is thak 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 thak, that is called as fetal cardiac activity. And what is the first sign of pregnancy on ultrasonography? Anybody? So again, very important point, please keep in mind that if this is the uterus, okay, anybody, for any pregnancy, if this is the uterus, what is the first thing what I see in the pregnancy? Yes sir, gestational sac. It is proper, well circumscribed, okay, with a good decidual reaction. So the gestational sac is always the first sign of pregnancy. Short form G-sac as we call it, gestational sac is first. And one more important MCQ, the second what you see is the yolk sac. And please comment in the chat box, please comment that by transvaginal sonography, please comment in the chat box, comment in the YouTube video. I will be giving you the answer over there, that sir, on transvaginal sonography, by when can I see the gestational sac on transvaginal sonography? So first sign of pregnancy on any sonography is the gestational sac. Second is the yolk sac. So please comment, when will I see the gestational sac? Earliest by doing a transvaginal sonography, and also by transabdominal sonography. Okay, so G sac is the first thing. Inside the G sac you get another circle, which is the yolk sac. Okay, my dear student. So the outer circle, black one, is a G sac. The inner circle is the yolk sac. Okay, and then you get the fetal pole, and then comes the fetal cardiac activity, which is a sign of live pregnancy. Moving on, very important topic, trisomy 21. Trisomy 21, that means your Down syndrome. And T1 screening test. Which is the screening test for detection for Down syndrome in T1? T1 is my short form for first trimester. Anybody? Is it the triple marker, quadruple marker? No. So in the first trimester, we do a dual marker test. Dual marker test is done in the first trimester. When? Sir, we generally do it between 11 to 12 weeks, 11 to 13. Even if you remember 11 to 12, that is okay. So remember that, it's 11 to 12 weeks is when we do the dual marker test. And what are the components of this dual marker test? Yes sir, HCG and PAP-A. Okay, HCG is human chorionic gonadotropin, and PAP-A is pregnancy associated plasma protein A. Okay, and you will comment in the YouTube video, in the chat box, that which is going to increase, what is going to decrease if the baby is having Down syndrome. And important, it is a screening test. Okay, so dual marker test. And one more, lot of confusion, student do not know this. I'm surprised कि sir ये dual marker test कैसे करते हैं? So dual marker test is, how is the test done? Amnio, CVS? Wrong. Kachra, dustbin. Okay, please understand this. This dual marker test is done on maternal serum. Okay, it is a simple blood test which is done on maternal serum. Is this understood to all of you? And what is the confirmatory test? Yes, so here we ask the screening test, the confirmatory test which I do in the first trimester. Please understand this, in the whole world, the confirmatory test is karyotyping only, karyotyping. But better answer I will give. So karyotyping, because I want to know if the baby is having 21 extra chromosome, like 47 chromosome, like you may have 46 chromosome. Here we want to see if there's an extra chromosome 47 on the 21st chromosome, that's Down syndrome. So karyotyping. And how will I do the karyotyping in the first trimester? Chorionic villus sampling. Is this understood to all of you? So chorion villus sampling or chorion villus biopsy. And please understand this, chorionic villus sampling is always done in the first trimester, okay, after 10 completed weeks, again between 11 to 13 weeks. So karyotyping is a confirmatory test. The dual marker test is a screening test done on maternal serum. It's a simple test done on mother's blood. And anybody, NT scan. What is this NT scan? Again, very important. So if this is the baby, okay, this you get the baby ka side profile, and then this is how the baby would look like. Okay, then we zoom in over here and we get a translucent space called as NT. What is NT? Anybody? Nuchal translucency. And this NT scan, my dear student, is again done between 11 to 13 weeks of gestation. Very, very important. And along with something extra information, NT scan तो करते हैं, उसके अलावा we also check for nasal bone, and therefore nowadays it is called as NBNT scan. NBNT scan. Why? Because sir, nasal bone should normally be present, because sir, if the baby has Down syndrome, one of the marker is absent nasal bone. So absent nasal bone in babies with trisomy 21, Down syndrome. Okay, and all of you also please comment that sir, the NT scan, when is it? I told you what is the cutoff, that how much should this NT value be. Can anybody tell me? I'm giving you a clue. Sir, this NT, when I measure, it should be 1 millimeter, 2 millimeter, like this. Okay, example, it should always be less than what? So up to what is considered NT? Normal. And if it is more, you have to suspect Down syndrome. Again, please understand, it's a screening test. So this is a ultrasonography called as NT scan, or better nowadays called as NBNT scan. Why? Because absent nasal bone is one of the markers for trisomy 21. Again, a short thing. What are the 6 early pregnancy sign? Okay, so this is a total confusion. Goodell sign, Jacquemus sign, Piscacic sign. I'll explain to you, all of you. Okay, Palmer's sign, Hagar's sign. So what is all this sign? Okay, so point number 1, please understand this, that in early pregnancy, the vagina, because of congestion, okay, because of congestion, the vagina and the cervix can appear as bluish in color. That is your Jacquemus sign or Chadwick sign. Okay, now all of you take your finger, do the examination, because touch your lips, touch your nose. Why? Okay, please understand this, because if you don't become a gynec, you will not get to do a PV. The non-pregnant cervix feels like the tip of the nose, thoda sa firm hota hai, and pregnant cervix feels like the lips. Okay, so lips should be soft. Yes or no? Good. If the lips are soft, it is good. If you are very unlucky for you, unlucky for your partner, then the lips will be firm. Okay, so if the lips are soft, it is good, isn't it? Yes, lips are soft, that is good. That is your Goodell sign. Goodell sign is cervical softening. Okay, now again, when I do a PV examination, we can feel the pulsations. Okay, we can feel the pulsations of the uterine artery in the lateral fornices. That is the Osiander sign. I'm showing you the whole table. And on bimanual examination, one hand above, one hand inside, my fingers will approximate. That is what? Hagar's sign. Okay, so all of you please pay attention. Very, very important. 5-star, 7-star. Again, one MCQ surely coming from this. The Jacquemus sign or the Chadwick sign is the vagina becoming dusky in color or bluish discoloration. okay, or light slightly bluish or dusky because of congestion. Osiander sign, so this is mug up, no explanation, is the pulsations which I feel in the fornices, lateral fornices. This is the pulsations of the uterine artery. The second column, if you don't remember, it is okay. No need to remember second column, all are in early pregnancy. So don't remember this second column, I am okay with it. Okay, so there's no need to remember the second column, that is fine. You just remember the first and the last. As I told you, cervix will soften, that is the good L sign. How will the cervix soften? Feel like the lips, okay, like it will look like the lips, okay, feel like the lips, okay. Then on bimanual examination, the fingers will oppose or approximate, that is the Hagas sign. And regular rhythmic contraction you feel during bimanual examination, that is the Palmer's sign. The last and the difficult virgin MCQ, Pisca cake sign. Again, very theoretical, very stupid. I've never seen it. It's very theoretical, but just to trouble the student. Now what is this? That understand this, the question ये आएगा कि when do I see Pisca cake sign? तो क्या है, प्लीज आपको याद रखना है कि suppose sir it is a very early pregnancy, okay, it is a early pregnancy, okay, and suppose it is a lateral implantation. That means the pregnancy has got implanted on one side, a lateral implantation. Then sir, when I do a PV examination, this side of the uterus will appear slightly bigger and this side will slightly appear smaller. Okay, so this is your, so uterus appears like this. Obviously as the pregnancy will grow, pregnancy center में आएगा, and then we are going to get a proper symmetrical enlargement of the uterus only, because pregnancy is symmetrical enlargement. But the question which can be asked to you is that, sir, why is this Pisca cake sign? That, sir, there is asymmetrical enlargement, what I told you. So this side is appearing slightly bigger, this is slightly smaller. So asymmetrical enlargement of the uterus seen in lateral implantation. That is the MCQ. That is your Pisca cake sign. So please keep this in mind. Any of them can be asked to you in the exam. Extremely important. Which prostaglandin is used for cervical ripening? That means when I want to induce the labor, cervix is very hard. Please understand this. PGE2. And what is PGE2? Another name, dinoproston. Okay. What is PGE2 available? Sir, PGE2 का gel होता है, gel. It's a gel which I put inside the posterior fornix vagina on the cervix. Brand name you don't have to remember, but remember Cerviprime gel. Okay, Cerviprime is a brand name, Cerviprime gel. Cerviprime gel is a dinoproston gel which is PGE2. And extremely important, anybody, PGF2 alpha कहाँ पे use करते हैं? Sir, PGF2 alpha is a drug which I used in management of PPH. PGF2 alpha is what? Sir, carboprost. And please understand this, what is the absolute contraindication? Bronchial asthma. Short question. It has come in the past. Again repeat hoga. Why? Because sir, it is PGF2 alpha. It's a bronchoconstrictor. So sir, bronchial asthma patients, we can never use this PGF2 alpha. So remember, PGF2 alpha is an injection. It is an injection given by intramuscular route. It is an injection given by intramuscular route, used for PPH only mainly, and it's called carboprost is the name. And absolute contraindication, bronchial asthma. Is this understood to all of you? And what is the contraindication for methergin or methyl ergometrin? Okay, methyl ergometrin or methergin. Please understand it, it's a vasoconstrictor. How will you remember it? Remember the word H. Triple H. Why triple H? Okay, why first H is heart disease patients. Okay, why? Because sir, it will increase the preload, afterload, the coronary arteries can go in spasm. So heart disease patient, I can never use methergine or methyl ergometrin. So first wala is heart disease. Second, very very important, my dear student, it's a vasoconstrictor. It will increase the blood pressure. So hypertensive disorders, that means preeclampsia and eclampsia patients. Okay, preeclampsia and eclampsia patient. And third very important point, remember, half delivery of twins. What is the meaning of half delivery of twins? It is my mnemonic to make it triple H. Half delivery of twins का मतलब क्या है? Common sense, all of you look on the board. Okay, sir, suppose it's a twin pregnancy and only if the first baby is out, the first baby has already been delivered, okay, and one baby is still inside. Now can anybody tell me what will happen if I give methergine? Sir, methergine causes a strong contraction of the entire uterus. Both upper lower segment will contract together and rupture uterus, and this baby can die fetal distress. Okay, so as long as baby is inside the uterus, I can never give methergine. And therefore remember, my dear student, methergine or methyl ergometrin is never to be used for induction of labor. Never. Rupture, you will have to go to jail. Rupture uterus, baby dead, mother dead. Methyl ergometrin has got one and only one role for PPH, prevention and treatment. I can only use it in PPH. So I repeat, आपको एग्जाम में हार्ट डिजीज, hypertensive disorders and twins after first baby delivery. But twins after first baby delivery matlab half delivery of twins, what I explained to you. Half delivery means, sir, one baby is delivered, one is still inside, I cannot use methergine. Yes, once both the babies are out, methergine can be given. Okay, so please keep this point in mind. Okay, moving on. Which is the most common malpresentation and what is the most common malposition? Total confusion. So vertex is the presenting part. So when I say malpresentation, breach is the most common malpresentation. Okay, my dear student, that means instead of the normally, as all of you know, it is head down. When it is like this, and the head is up, we call it as breech. Okay, but what is the meaning of the word malposition? Sir, malposition में head ही है. It is a head delivery. But sir, normally occipito होता है anterior. Occipito anterior is considered normal. So when it is occipito posterior, we use the word malposition. So please understand this, malposition is OP, occipito posterior, and here also right occipito posterior. ROP is more common compared to LOP. So I repeat, presenting part is the head only. It is a head delivery only. When I say occipito posterior, it is a head delivery only. But normally the occiput is anterior. That's why I have written normal. Malposition matlab occiput is piche. So occiput is towards the sacrum. That is called as OP. And ROP more common compared to LOP. Most common cause for breech, prematurity. Because starting में many babies are breech, then baby starts to rotate. Most common cause for prematurity, breech is your prematurity. When do we do the external cephalic version? I want to rotate the baby. Don't wait for the labor to start. And many books wrong. They are saying 32, 34 weeks. Wrong. Please understand this. The ECV, you have to wait for the baby to turn, because by 36, 37 weeks the baby can rotate on its own. So the best time to do ECV is at around 36 to 37 weeks as per the ACOG criteria. Don't wait till 39, 40 weeks because the labor can start. Okay, so external cephalic version best done at 36, 37 weeks. because we are waiting for the baby to turn on its own. And then also, if the baby is not turning, then you may want to rotate the baby, and that is done at around 36 to 37 weeks. Okay. The next important one liner: most common implantation in ectopic, or most common site for implantation in ectopic. So remember students, ampullary part. Okay, ampullary part is the most common, followed by the isthmus. Okay, so ampullary pregnancy, when we say most common site, it is the fallopian tube. Okay, so fallopian tube, and in the fallopian tube, which is the most common site, ampullary part. Now, earliest to rupture, which ectopic is earliest going to rupture? So please understand this: the isthmus. Okay, isthmic pregnancy or isthmus. Okay, the isthmic pregnancy can rupture at around 6 weeks. Okay, the ampullary pregnancy would rupture at around 8 weeks. So ampullary is the most common site, but earliest rupture is isthmic. And very important, difficult MCQ, last to rupture. Anybody? And therefore, please remember this one question could also be asked: which has the maximum blood loss? Why? Because it is last to rupture, interstitial variety. Now, what is this interstitial variety? And it can rupture at around 16 weeks of gestation. So please keep in mind, so it's like a bigger bomb blast, okay, because it will grow till 16 weeks and then fatega. Now, what is this interstitial variety, my dear students? The first part of the fallopian tube. What is the meaning of interstitial variety? Please understand this: the intramyometrial part. So sir, this is the uterus, and all of you know the fallopian tube goes from here like this. So the first part, this first part of the fallopian tube, this is called as interstitial. The ectopic is over here, and since it is intramyometrial, it has got some distension capacity. So ye badhega, 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 and then when the pregnancy is 16 weeks, then this interstitial can rupture. Okay, so interstitial means the first part of the fallopian tube, the part of the fallopian tube which is inside the intramyometrial portion. Okay, the intramyometrial portion, that is called as the interstitial, or the first part of the fallopian tube, that is last to rupture. So keep in mind, most common site, ampullary pregnancy. Isthmic pregnancy is rupturing at around 6 weeks, and interstitial last to rupture. And since it is last to rupture, also maximum blood loss. Moving on, what is the preferred treatment for unruptured ectopic? Please understand this. Student directly see ectopic pregnancy and they say laparoscopy surgery or laparotomy surgery. No, unruptured ectopic, methotrexate. Of course, there are certain criteria for that, but injection methotrexate, or MTX as it is called, is given by intramuscular route. It is always the preferred treatment. What is the criteria? Of course, sir, it should be, the patient should be stable. So in a patient who is hemodynamically stable, that is unruptured ectopic. And what should be the beta HCG criteria for methotrexate, and what should be the gestational sac criteria? Anybody? Short MCQ, पेन पेपर पे लिख के ले लो, आने वाला है. So gestational sac, my dear student, should be less than 4 centimeter. So if I have a stable patient which is an unruptured ectopic, gestational sac is less than 4 centimeter, and the beta HCG is less than 5000 micro international units per ml. Please by heart this number. If the initial beta HCG before giving methotrexate is less than 5000 micro international units per ml, gestational sac is less than 4 centimeter, and the patient is stable, then we always prefer to give methotrexate injection IM. Is this understood to all of you? So please keep in mind. And after giving methotrexate, how do I know my treatment is working or not? Please comment in the chat box. Okay, after giving methotrexate, how do I know? What do we monitor? And that the treatment is working or not? How do I come to know? Okay. Moving on, to now certain gynecology. So all this what we discussed were very important from obstetrics point of view. Now moving on to some gynac, very important one-liners. Most common cause of female infertility worldwide. Now please understand this, worldwide for female infertility, the ovarian factors. Ovarian factors, that means that, sir, it could either be an ovulation that the female is not ovulating, or it also means like the ovarian reserve is going down, diminished. So either, sir, basically egg, ovarian factor, or egg problem. Sir, either it's an ovulation, the female is not ovulating, or she is not ovulating because of diminished ovarian reserve, the egg capacity. Very important word, ovarian reserve. I'll explain to you in a minute. Now इसमें ध्यान ये देना है कि वर्ल्ड वाइड पूछा है तो हम ओवेरियन फैक्टर मार्क करेंगे. बाई चांस इफ दे आस्क यू what is the most common cause of female infertility in India, then in India, my dear student, because TB, gonococcal infection, genital TB, so then tubal factor. Okay, so tubal factor we will remember because of TB and infection. So I repeat, worldwide the most common cause is ovarian factor. Specifically, if in India they ask, then tubal factors are number one. Then comes the ovarian factor. Okay, so please keep this in mind. The gold standard investigation for tubal patency test. Okay, please understand this. HSG is not. HSG is considered the initial investigation. The gold standard or the best is your laparoscopy. Okay, and what do we do in laparoscopy? We put some blue dye. What is it, blue dye? Yes, that is also the question. We give a methylene blue dye. The methylene blue dye is injected through the cervix. I will put in a telescope and I will see whether the dye is coming out of the fimbrial end or not. This is called as laparoscopy chromoperturbation. Okay, why? Because this is with your seeing is believing, with your own eyes. With your own eyes, all of you look on the board. We will put in a telescope through the anterior abdominal wall. Okay, this is the patient's uterus. This is the uterosacral. This is the fallopian tube. Okay, so we are putting in a telescope. Okay, this is laparoscopy. Okay, and then here would be the ovaries also. Okay, and now a blue color dye, a methylene blue dye is injected from the cervix. Okay, the blue color dye is injected from the cervix and the dye will come and enter the fallopian tube, and then what will happen? The dye will come out from here and everybody jumps in the OT. Blue hai pani. Okay, so blue. So this, my dear student, is the best investigation. This is your laparoscopy and chromoperturbation. Chromoperturbation done with what dye? If they ask you, methylene blue dye. Okay, that is the gold standard or the best investigation for tubal patency. Now, when we look at unexplained infertility, female factors 35 to 50%, male factors 35 to 40%, and remember, my dear student, 10% patients, 10 to 15%, but you can remember as 10% mainly. 10% is unexplained. Unexplained means bad luck. We do not know. What is the meaning of unexplained? Sir, all possible investigations are normal. There is no reason found. Okay, so 10% cases. Again, a very important number to keep in mind, 10% cases. So in the exam, if they give you a range, you can mark 10 to 15, but 10% cases are unexplained infertility. Now, very important. What is this ovarian reserve? Ovarian reserve is the capacity of the ovary to produce eggs. Okay, and here, my dear student, AMH is the answer. AMH is a anti-Mullerian hormone, and anti-Mullerian hormone AMH is the best marker. Okay, it is the best marker for ovarian reserve. Okay, is this understood to all of you? And the important part is AMH can be done on any day of the menstrual cycle. If AMH is not in the option, and please understand the thing, marker for ovarian reserve, taking the blood marker, then serum FSH, follicle stimulating hormone. Why? Master servant relationship. If the ovary is not working, the brain will shout more. And as the ovarian reserve, so what's the meaning of ovarian reserve? So, capacity of the ovary to produce eggs. So as the ovarian reserve is decreasing, if the ovarian reserve is decreasing, what will happen to AMH? Sir, AMH will also decrease. Okay, so low AMH is bad. Low AMH means that, sir, patient is approaching menopause, patient is approaching ovarian failure, the eggs are getting depleted. But when the ovarian function declines, the master bolega aur kaam karo, and therefore clap, that FSH is going to rise. So please, my dear student, understand this, that dono ka meaning same hai. When I say diminished ovarian reserve, that means that the egg capacity to produce egg, the ovary capacity to produce egg is declining, menopause is nearer. How will it reflect? So the AMH level will go down, but the FSH level will increase. Okay, clap if you have learned something new. Why? Because sir, AMH comes from the ovary only and FSH is from the pituitary. So diminished ovarian reserve is indicated. So the best marker for the ovarian reserve is the AMH, that is you mark first, and AMH values will be decreasing. If AMH is not in the option, then serum FSH, and also nowadays on ultrasonography we look at the antral follicle count. On day 2, beginning of the cycle, how many small follicles, the antral follicle count, that is also the marker for ovarian reserve. But AMH is a blood test, so when they ask you the serum marker, AMH. Now please understand, there's something very new. WHO guideline for the sperm count should at least be, please understand this, many years back 20 million was the answer. Then the WHO changed it from 20 to 15 million per ml, and many students still know that, sir, 15 million per ml is the answer, and many students will mark this only. But as per the latest 2022-2023 WHO guidelines, now the sperm count should at least be 16 million. WHO को ना कुछ और काम धंधा नहीं है, अपने डॉक्टर्स को परेशान करने के लिए सब गाइडलाइन चेंज करते रहते हैं. तो पहले 15, अभी 15 का 16 करके, व्हाट इज द बिग डील, आई डोंट नो, बट 16 million per ml. Now please mark it in exam, 16 million per ml is at least. Okay, so the sperm count should be, as per the WHO guideline, should be at least 16 million per ml. 15 million is now outdated, 20 is also outdated. Okay, and million per ml. Okay, should be the at least sperm count. And please comment in the chat box when we go for semen analysis testing. Lot of confusion among the student. What is aspermia and what is azoospermia? Please comment in the chat box type. I'll give you the answer over there. What is the meaning of aspermia and what is the meaning of azoospermia? Total confusing word, aspermia, azoospermia, and many students make a mistake in this. Okay, moving on. First line treatment for PCOS. Okay, very important. Also comment which criteria. Okay, what criteria we use for PCOS? The Rotterdam criteria we should know. And the first line treatment for PCOS is what, my dear student? Don't jump to Ocipil, Clomiphene, Letrozole, Metformin. No, lifestyle modification. Why? Because, sir, there is insulin resistance, and therefore diet. Okay, diet, exercise, whatever is in the option. Okay, diet, exercise, maintaining weight, losing weight, and therefore lifestyle changes or lifestyle modification, proper sleep pattern. Okay, and lifestyle changes or lifestyle modification is the first line treatment or management suggested to all patients of PCOS. Of course, along with diet and exercise is understood. Okay, Now, everybody, what is the characteristic ultrasound finding called as? Yes, the necklace of pearl pattern. But why I want you is necklace of pearl, or also called as string of pearl patterns. And what is this? Please understand this. How many follicles? Okay, how many follicles? So they are multiple small follicles arranged in the periphery of the ovary. And can anybody tell me, if I measure this follicles, what will be the size of this follicle? Yes sir, all the follicles will be in the range of 2 to 9 millimeters. Okay, 12 or more than 12 follicles, 12 or more than 12 follicles, 2 to 9 millimeter inside, arranged in the periphery along with echogenic stroma. That is the typical necklace of pearl pattern or string of pearls appearance, whatever you want to call it. Now, इसमें और एक recent advances है, my dear student. Clap and thank me on the day of the examination is my guarantee. Okay, sir, this 12 or more than 12 follicle is when we do a transvaginal sonography with a normal probe, 2.5 300 megahertz. The latest thing is that if 8 megahertz probe is used, if 8 megahertz probe is used, then the number of follicle 20 or more than 20 follicles. Okay, is this understood? But specifically, if they specify in the exam that if a 8 megahertz probe is used, that's a high intensity probe, high frequency probe, then yes, follicle size criteria is the same, 2 to 9 millimeter size, but then there will be 20 or more than 20 follicles. Okay, it's called FNPO, follicle number per ovary. What is FNPO? Follicle number per ovary. Absolutely virgin MCQ, PG level MCQ. At your level, remember 12 or more than 12 follicles, 2 to 9 millimeter in size. But if 8 megahertz probe is used on USG, then there should be 20 follicles. Okay, is this understood to all of you? Most common endocrinopathy in the reproductive age group in female, PCOS, extremely important, polycystic ovarian syndrome or polycystic ovarian disease. And remember this, till now all students say sir multi PCOD matlab multiple cyst in the ovary. Wrong, they are not cyst. If any one of you friend relatives kisi ko bhi PCOS, there are no cyst in the ovary, multiple small follicles. Okay, so listen to my detailed lecture, you'll get an idea what's the difference. There are no cysts in the ovary. Okay, now very important again, the first student क्या करता है, directly पढ़ता है first drug of choice clomiphene. They will mark clomiphene citrate. Wrong. Okay, clomiphene citrate was the first line drug. Today for ovulation induction, specifically in PCOS, letrozole is the answer. Letrozole is giving better pregnancy rates, higher live pregnancy rates, better ovulation rates, and therefore letrozole is preferred over clomiphene, and it is the first drug of choice for ovulation induction in patients of PCOS. Please keep this in mind. Extremely important MCQ. Anybody? Longest acting IUCD, how many years? Longest acting is 10 years. And what is this? Copper T 380. Copper T 380. How will you identify it in the exam? Please understand this, that sir, it is the only copper T jiska even on the horizontal arm there is copper over here also. Of course, there is a copper wire over here. There is a copper wire over here, but there will be copper on the horizontal sleeves also. Okay, so the longest acting is your copper T380. Myrina, also called as LNG intrauterine device. What is the total LNG content? Now again students say, sir, another name is LNG 20, and therefore they will say 20 is the total. No, the total content is 52 milligrams by heart. But then why do I call it LNG 20? Because sir, 20 microgram per day is released in the uterine cavity. Okay, so I repeat, the total LNG content is 52 mg, but 20 microgram per day is released. Okay, मोस्ट कॉमनली वी यूज्ड एज इमर्जेंसी. ओके, कभी ना कभी आपने सुना होगा, यूज किया होगा आपके फ्रेंड्स ने, आपने आई पिल. ओके, बट आई पिल इज द ब्रांड नेम. आई पिल इज द ब्रांड नेम. ओके, सो आई पिल नहीं है. मोस्ट कॉमनली यूज्ड इमरजेंसी कॉन्ट्रासेप्शन इज, व्हाट इज दैट आई पिल? Yes, sir. Single tablet of 1.5 milligram LNG, levonorgestrel. Okay, 1.5 milligram levonorgestrel, single tablet, एक ही गोली. Okay, and what is the emergency window for LNG? Yes, 72 hours. Okay, within 72 hours, as early as possible, we have to give this emergency contraception, single tablet of 1. Oral, tablet, single tablet, I pill. Is it clear to all of you? Now, very, very important. OC pills or combined oral contraceptive pills, both mean the same thing. When they say COC or OC, decreases the risk of which cancers? तो कैसे याद रखना है? CEO, clap. CEO का मतलब क्या है सर? कोलोन कैंसर. कोलोन कैंसर will become less. Endometrial cancer will also become less. And O से है ovarian cancer. Okay, so OC pills have got lots of benefits. We use them in acne, we use them in PCOS. Apart from contraceptive benefits, they've got lots of benefits, and specifically when the patient uses it for a few years, there is decrease of colon cancer, endometrial cancer, and ovarian cancer. Now, very, very important, the new MTP guideline says that, sir, MTP is allowed till 24 weeks of gestation. Yes or no? Yes. But my dear student, for failure of contraception, for failure, this 20 to 24 is for fetal anomaly or chromosomal or genetic defect in the baby, or for rape and sexual assault victim. For failure of contraception, MTP is still allowed only till 20 weeks of gestation. Please keep this in mind. Sure, short MCQ coming. Okay, for failure of contraception, MTP allowed only till 20 weeks. Is this understood to all of you? So please don't make a mistake in this. Virgin MCQ. What is virgin MCQ? My students will know this, the MCQ never asked before but will come in the future exam. That if a patient has got sickle cell anemia and multiple sickling episodes, what contraception I will give her? Highest level, please understand this, DMPA, depomedroxyprogesterone acetate injection is of course a contraception, and this exact reason not known, it has been known to decrease the sickling crisis and sickling episodes, and therefore for patients with sickle cell anemia, DMPA injection. And please comment in the chat box, ये जो injection है, how frequently we give it. Anybody? We have to give it every monthly, 2 monthly, 3 monthly, 6 monthly. How frequently is this injection DMPA given? It is given by intramuscular route. Okay, it's a birth control and it helps the patient, by the way, also in sickling crisis. If you have a sickle cell anemia patient, DMPA is better or preferred. Okay, now anybody, contraception of choice in the postpartum period, and many will mark as POP, DMPA, breastfeeding. No. Okay, please understand this, that yes, progesterone is safe and DMPA and POP can be given, but please understand this, okay, I want, when a patient, the question is in the postpartum period, that means she has just delivered one baby. She has delivered one baby and she wants to wait for at least 2 to 3 years for the second baby, 2 to 3 or even more. and therefore what we require, they are called as spacer devices, and therefore IUCD, and therefore IUCD also called as LARC. Very hot word, LARC. What is LARC, sir? Long acting. Yes or no, sir? IUCD is long acting. 3 years, 5 years, 10 years. Long acting reversible contraception. Okay, sure, short. This is coming in the exam because, sir, a patient who has delivered just now in the postpartum wants to wait for 2 to 3 or even 5 years. She wants to wait. So, every day taking tablet is difficult, and therefore IUCD is preferred, and the contraception of choice in the postpartum period is IUCD. That is the best. If this is not in the option, then we can think of giving a DMPA injection or POP, all that. Okay, but IUCD is the best or number one preferred for the patients in the postpartum period because ek baar dal diya, very good. Now PPIUCD, what is PPIUCD? Postpartum. Again ये question आएगा, postpartum, how earliest IUCD can be inserted? Within 48 hours of the delivery. Please understand this. I can, in a vaginal delivery, I can do it immediately after the baby comes out, placenta comes out. While suturing episiotomy, we can put in the IUCD. So within 42, matlab within 48, but it's immediately after delivery. Okay, and if you are doing LSCS also, so both, whether it is on LSCS on OT table, you open up the patient for surgery, remove the baby, remove the placenta, put in the copper T, and then close the uterus. Okay, so whether it is LSCS or a vaginal delivery, immediately is the answer. Immediately we can do PPIUCD, but up to 48 hours we do it. Okay, within 48 hours we can do the PPIUCD. PPIUCD is postpartum IUCD insertion. Again, a short question. This is going to come in the exam for sure. Moving on. Asherman syndrome, the management is, and septate uterus, the management is, and directly students will mark laparoscopy, and wrong, clean bold. Please understand this. Laparoscopy is, I told you, from outside. You are seeing, I've shown the picture also today. I told you we see the uterus from outside. I've drawn. But Asherman syndrome is what? Sir, it is a intrauterine adhesions. Similarly, my dear student, the septum is inside the cavity, and therefore all of you look on the board. This is the uterus. Okay, where is the septum? Sir, septum is like this. This is the septum. And what is Asherman? Intrauterine adhesions. This is your Asherman. So the problem is inside the cavity of the uterus, and therefore what do we prefer, or what is the gold standard? Sir, hysteroscopy. Sir, I will go in through the hysteroscopy route, and through the hysteroscopy, so students will like Asherman syndrome, adhesiolysis, but specifically adhesiolysis, hysteroscopy. Hysteroscopic adhesiolysis. Why? All of you look on the board. Through the hysteroscopy scissors, you will go in and you will cut the adhesions like this. See this, you can use the surgery being done. I'm cutting the adhesions. That is called as hysteroscopic. And similarly, hysteroscopic, you can cut the septum. You have to cut like this, like this, like this, like this, and cut the septum. Is this understood to all of you? So when we have a septate uterus, laparoscopy has no role. Laparoscopy has no role because laparoscopy will see only the outer surface, which is normal, or there is not a problem. Okay, in Asherman syndrome, and in septate uterus the problem is in the cavity, and therefore Asherman syndrome hysteroscopic radiolysis, and septate uterus also not laparoscopy, we will go for hysteroscopy. Hysteroscopic, it is called hysteroscopic septal resection. Okay, through the hysteroscopy route we will go and we will cut the septum. Okay, so it's called hysteroscopic metroplasty, you can call it metro matlab metroplasty, or basically hysteroscopic septoplasty. All these words I use. Okay, metroplasty better septoplasty. Okay, or septal resection. Okay, metroplasty is mainly when you cut the lateral walls of the uterus. So hysteroscopic septoplasty or hysteroscopic septal resection is the word for your septate uterus and not laparoscopy. Okay, so hysteroscopic septoplasty or septal resection. Moving on, very important, short again, lot of students are cancer staging डर लगता है, लेकिन ये बाहर करके जाओ. Cervical cancer spreads laterally. Cervical cancer patient को होता है तो it spreads laterally. It reaches the lateral pelvic wall and it can engulf the ureter and give rise to hydroureter hydronephrosis. This is stage 3B. Please by heart this. Please by heart this. Okay, it's a cervical cancer with hydroureter hydronephrosis and non-hydronephrosis and non-functioning kidney. They will give in the question. Non-functioning kidney, it is 3B. And also that, my dear student, most common cause of death in patients of cervical cancer, यूरेमिया. यूरेमिया या रीनल फेलियर. कैसे होगा यूरेमिया? सर 3B से होगा यूरेमिया. Cervical cancer will spread laterally. ये है cancer cervix, will spread laterally, reaching up to the lateral pelvic wall, and it will engulf the ureter, giving rise to hydroureter hydronephrosis. This is stage 3B. Please by heart this. Is this understood to all of you? Now, in the entire OBGY, if I have got primary amenorrhea with absent uterus, only two possibilities are there, and that is RMKH syndrome, Rokitansky-Meyer-Kirschner-Hauser, and second is your androgen insensitivity syndrome, also called as testicular feminization syndrome. I repeat, primary amenorrhea, absent uterus, only these two. And please comment in the chat box, how do I further differentiate between the two? What clinical feature will tell me if the patient is RMKH or androgen insensitivity, also called as testicular feminization syndrome or feminizing syndrome? Is this understood to all of you? Yes. Very simple. Primary amenorrhea, web neck, short stature is your Turner syndrome. Turner syndrome, by the way, is the most common cause. One more MCQ. Most common cause for primary amenorrhea is your Turner syndrome. Okay, it has got a web neck, short stature. And tell me about the uterus. Anybody? Turner syndrome, is it absent uterus? No. Turner syndrome, the uterus is chin2, underdeveloped. There is hypoplastic uterus, but the uterus is present. It's not absent uterus. Is it clear to all of you? RMKH karyotype, AIS karyotype. Sir, RMKH is like a normal female 46XX. Androgen insensitivity is 46XY. And Turner syndrome, all of you should know, it is 45XO. So this is expected as match the column, and this is FMGE exam. That's a new style of asking question. Match the column आएगा, ये side पे all the syndromes, ये side पे karyotyping. So RMKH 46XX, AIS 46XY, are Turner syndrome 45XO. Okay, and anybody Swyer syndrome. Again, student have a confusion. So Swyer syndrome is again a pure gonadal dysgenesis, and Swyer syndrome is also 46XY. Okay, is this understood to all of you? And please comment in the chat box that how there's only one difference. Okay, sir, AIS 46XY, Swayers also 46XY and primary member. But okay, so I'll tell you the answer, sir. In AIS it is absent uterus, जो मैंने बताया. Sir, androgen insensitivity, there is absent uterus. And in Swayers syndrome, the uterus is present. Okay, is this understood to all of you? So please keep in mind, Swayers syndrome is again 46XY, but with presence of uterus. Okay, so don't make a mistake in this. And all of you, my dear student, look at this beautiful handwritten notes which you're going to get in the app. Every student has told me that, sir, once we listen to your videos, within 2 to 3 hours, I can revise the entire notes, completely colored, handwritten font with all the integrated images, and best to revise after seeing the videos. The notes will get over 100% in 2 to 3 hours. And my dear student, is the best way. 3 months master class. 3 months, because exam is going to be in July. I can assure you that if with your current knowledge you are getting 10, 11, 12 MCQs correct, after seeing my video you're going to get 28, 29, 30 MCQs correct, because 30 to 35 MCQs are expected in OBGY, at least 30 for sure. So it's a major subject. And my dear student, as I said, minimum 15 marks. If with your knowledge currently you are getting 10, 11, 12, 13, 14 MCQs correct, after finishing my videos, just dedicate 40 hours on the app. I just want all of you. And if the subject is going to give you 30 MCQs, 40 hours is just what you need to give on my app. And all of you, your score will jump up minimum 15 marks more. From 12, 13, it will jump up to 27, 28. Majority of my students get 30 on 30 or 28, 29, 30. Seeing is believing. Every day, so many students are thanking me and saying, sir, we have become champion of OBGY. And when I get calls, okay, sir, among all 19 subjects, my best performance is in OBGY. Same thing will happen with you when you will walk out of the FMGE exam. You will tell me, sir, today I have cleared FMGE. I was getting stuck at 135, 140. I have crossed 150 barrier thanks to this OBGY, because here I am getting the maximum marks. And OBGY is a very scoring subject. Medicine, surgery, difficult to score. So don't miss out on this opportunity. Masterclass FMGE is the course. 3 months validity, only in 1400 rupees. 700 rupees gynac, 700 rupees obstetrics. What all you get the main theory lectures. As I said, it will get over in 40 hours only. Okay, don't get hassled by 65, because everybody says at 1.5 speed. So just 40 hours of theoretical lectures with rapid revision, MCQ discussion videos with the beautiful notes, of course mock test, and my timetable and guidance. So don't miss out, my dear students. The final opportunity, and here you can make or break. So many students who have failed 3-4 times and stuck up at 130, 140 score, have studied under my guidance for 2 months, 3 months, and crossed and cleared 140, 150, 160. They have got it because they get almost all marks in OBGY, and maximum score you will get in OBGY. Okay, my dear students, so quickly download the OGGuru app. These are all the tests I passed FMG thanks to your teaching. Only person who can give confidence in India without rattomaring. All this you can check for yourself, sir. Thank you for your lectures. Okay, I could attend all the questions in the exam just because of your OGGuru app, and all the students are there who have done very well in the upcoming exam, in the previous examination. Get in touch with me on phone and WhatsApp on this number. Download the OGGuru app, available for Android and iOS. Use the RG code YYMSTV, and do not forget to get in touch with me on phone and WhatsApp on this number. Do follow me on Insta also. Every day we're putting a lot of interesting content, and my YouTube channel, lots of important stuff for FMG NEET PG is available. Telegram also follow me, and here's wishing you best of. We'll be coming out with more such sessions also in the for the upcoming FMG NEET PG also. So do follow the channel, and please subscribe the OGGuru app for the best marks, and OBGY will become your most favorite subject and most scoring subject is my guarantee. Best of luck.